Hello everyone, I'm Dr. Jiji George, Professor and Head, Department of Oral Pathology, Babu Banarsi Das College of Dental Sciences, Lucknow. So today we'll be discussing about oral potentially malignant disorders. I've already explained leukoplakia in the last lecture. So today's lecture, I'll be dealing with the rest of them. Now, as you can see, I have also written the subheading as pre-malignant lesions. Now, pre-malignant lesions and pre-malignant conditions were the older names which were given for oral potentially malignant disorders. But then it was found that the potentially malignant disorders, though they carry the potential to become malignant, not all of them might necessarily become malignant. So actually, these are the disorders which have the potential to be malignant. So all of them together were characterized by WHO in 2017 as oral potentially malignant disorders. So though there is a historic importance of these two words, pre-malignant lesions and conditions, because they are often used these days as well in literature. So the pre-malignant lesions, so we'll be dealing with them separately. So I've already dealt with leukoplakia. I mean, these lesions are localized uh, problems. So I've already dealt with leukoplakia in the last class. So now today's class, I will be dealing with erythroplakia, leukoedema, as well as palatal changes in reverse smoking. Now, why I put the leukoedema in brackets is because it is a precursor to leukoplakia. It is not exactly considered to be orally potentially malignant, but then it is supposedly a precursor of leukoplakia. So having said that, let's start with erythroplakia. Let us start today's class. So first of all, I would start with erythroplakia. So what is erythroplakia? Erythroplakia, from the picture you can see, is a red colored lesion. All right. So a red colored lesion, erythro. What is an erythrocyte? An erythrocyte is basically a red blood cell. So an erythroplakia is actually a red colored lesion. All right. So which there are a lot of red colored lesions, but like leukoplakia, erythroplakia can also not be included in any other lesion. So that is when you call it as an erythroplakia. Matlab, you can have a lot of lesions which are red in color. A simple inflammation can also be red in color. But then if you are able to figure out, yes, this redness is due to lichen planus or this redness is due to squamous cell carcinoma, then you cannot call it as erythroplakia. You can only name it as erythroplakia when you are not able to give any other reason for that red colored lesion. All right. So you can see that this is a large area on the lateral surface of the tongue, which is red in color. And somewhere it is papular, and here it is nodular. So you can see where I'm moving the cursor. It is nodular because it is elevated. Here also it is elevated, but then not as elevated as this area. So you can see that how sharply it is demarcated from the surrounding areas. All right. So this can be due to trauma also. It can be due to any reason. But then as of now, clinical picture, you can actually see a red colored area, which is sharply demarcated from the rest of the normal area of the tongue. Now, let's come to what it is. Now, it is defined as a red patch that cannot be clinically or pathologically diagnosed as any other condition. So, if it was a white patch which was similar, then you would have called it as a leukoplakia. So, there are lesions called as erythroleukoplakias, where you find white lesions, white areas along with red areas. All right. So they are called as erythroleukoplakias. Now, or speckled leukoplakias. Fine. So here, now almost all erythroplakias show epithelial dysplasia. We have already discussed epithelial dysplasia in the last class, wherein I told you that there are some architectural features and then some cytological features. So cytological features are seen on the cellular level. That would be something like your what do you say, nuclear cellular pleomorphism or nuclear cellular hyperchromatism. Then you would have poikilocarinosis. You would have altered NC ratio. That is a maximum of NC ratio can come up to 1:1. So there are a lot of the dysplastic features which I spoke to you about. So all these erythroplakias will show epithelial dysplasia. In a leukoplakia, it was different, because in a leukoplakia, some of the white lesions could show mild dysplasia, some others could show moderate dysplasia, and some of them could show a severe dysplasia. But here, all of them will definitely show varying degrees of dysplasia. All right. Then it can even be a carcinoma in situ or an invasive squamous cell carcinoma. Now there is a concept which I want you to understand out here. That is that erythroplakia is clinically a red lesion. So when I use the word erythroplakia, I mean to say that we are talking about a clinical entity. A clinical entity means आप clinic में what do you see in the patient is a clinical entity. All right. So a clinical picture of the patient is a red lesion. But this red lesion, when you take a biopsy, can be anything. It can be epithelial dysplasia. It can even be carcinoma in situ, that is top to bottom changes, or it can even be an invasive squamous cell carcinoma. Matlab, an oral cancer can also show itself to be a red colored area or a red lesion. All right. So the concept that you understood is that whether the lesion is white or red does not matter. If you take the biopsy, you will be able to see either dysplasia, carcinoma in situ, or invasive cancer, whether it is a white lesion clinically or a red lesion clinically. All of them can be equivalently risky. All right. So you have to take a biopsy to rule out what exactly the condition is. Coming on to differential diagnosis. Red colored areas in the oral cavity can be seen due to any reason. It can be a non-specific mucositis. What do you mean by mucositis? Itis is inflammation of the mucosa. So non-specific inflammation, malab you took something like a hot cup of coffee and burnt your palate. It will burn, create a white slough. The white slough will move away, and then you will find a red area. Then, or you have kind of had a aspirin tablet, instead of swallowing it, you kept it inside the label mucosa. It burnt the mucosa. That will again cause a red colored area. Or in conditions like candidiasis. Candidiasis is a white lesion majorly, but then there are conditions called as erythematous candidiasis, where the candidiasis will also be red in color. So this can also be a differential diagnosis for erythroplakia. What do you mean by differential diagnosis? Lesions which look similar, which have similar features. So you're not able to differentiate whether it is an erythroplakia or an erythematous candidiasis, or a vascular lesion like a hemangioma, or maybe erosive lichen planus. That is when you call it as a differential diagnosis. Psoriasis is a skin lesion. We'll come to that later. Vascular lesions, for example, benign tumors like hemangioma, you must have done in your second year. These are also red in color. Now, erythroplakia is not as common as leukoplakia. It is less common, but then it has a greater malignant potential. What I mean to say is, if you have, say, 10 cases of leukoplakia, if at all one of that leukoplakia shows a malignant potential, and if you see 10 cases of erythroplakia, maybe 5 of them might show malignant potential. What I mean to say is, erythroplakia, the prevalence of erythroplakia is more rare than that of leukoplakia. But when seen, it carries a higher risk to become a malignancy than a leukoplakia. So earlier, this lesion was called as erythroplasia of Quereth, which was actually diagnosed in other organ parts. Now, that's a clinical picture of erythroplakia, which I've already showed you. Now, again, the concept I would like to repeat, that it is a red colored lesion that you are seeing, but it is not necessary that this is just a dysplasia. This definitely will be a dysplasia, but then it can be a carcinoma in situ, or it even can be into the stage of an oral cancer. All right. So you have to take a biopsy to rule out if it is an oral cancer or not. So clinical features, it can be seen mostly in older individuals of more than 65 years of age. Site can be anywhere, but floor of the mouth can be a very dangerous place to have. I've already told you, even if it's a leukoplakia, or oral cancer or even a erythroplakia. If you happen to see that in the floor of the mouth, that is a more scarier situation to be in, because floor of the mouth has got very loose mucosa. So there are chances that, and the epithelium is very thin, and there are chances that it can get dysplastic more faster, and it can invade the underlying connective tissue more faster. All right. So invasion is very dangerous to have, because that is the stage when it goes into oral cancer. Now, see the next point. It is a well-demarcated erythematous macule. So, well-demarcated because you can actually demarcate the borders from the surrounding areas. Erythematous macule, it's a red-colored macule. Macule is something which you can see but not feel. So, if it is a flat lesion in the initial stages, you can see the red color but you cannot feel it. So, that's a macule. Or a plaque. Plaque is a larger area which you can see and obviously feel. All right, with a soft velvety texture. It will not be similar to the rest of the oral mucosa. So in the picture, you could actually see that the color is red in color, and some areas it is elevated more and some areas it is elevated less. But you could actually differentiate the margins very clearly. All right. So it is usually asymptomatic because the patient might not have pain. So only if the patient has pain, he'll come to you. Or if he happens to see this scary looking red lesion, he happens to see it during his brushing or something, then he might come to you saying that, doctor, I developed it some time back. Can you help me? What is it? So there are three types of erythroplakia clinically. One is homogeneous. So by now, I'm sure you know the word homogeneous. It just means it is uniform. All right. So a homogeneous leukoplakia would look uniformly white in color, but a uniformly red colored lesion can be called as a erythroplakia. So an erythroplakia can look homogeneously red in color. So homogeneous erythroplakia will be uniformly red in color. Now, erythroplakia can be interspersed with leukoplakia. That is when you call it as a speckled erythroplakia. That is, or a speckled leukoplakia. If it's a predominantly white lesion with some red spots in it, you will call it as a speckled leukoplakia. But when it is a predominantly red lesion with some white spots in it, you will call it as a speckled erythroplakia. I hope you understand the concept. Whatever is predominant, matlab the white area is larger, you will call it as a leukoplakia, and only red spots are there, that will be a speckled leukoplakia. But if it's a entirely red lesion with small spots which are white in color, then you will call it as a speckled erythroplakia. All right. So coming on to histological features, that is very important. Now, before reaching the histological features of an erythroplakia, let me go back to what I discussed in leukoplakia. So in the last lecture, I said that a leukoplakia is white in color due to two reasons mainly. One is because the underlying blood vessels which contain erythrocytes are masked. Why? Because the thickness of the epithelium increases or increase in keratinization takes place. Now, if the increase in thickness of the epithelium happens, the acanthosis or the spinous cell layer is very thick in nature. So obviously the thick epithelial layer is going to mask the underlying uh, red blood cells inside the blood vessels. So you will not find the red color or the pink color. So it is more whiter in nature. The second reason could have been that the stratum corneum is more thicker. So if keratin is more thicker and the keratin is moist in the saliva, there are chances that the lesion will look white in color. So similarly, there is a histological basis due to which your epithelium looks red in color. All right. So red in color is mostly because you are able to see the RBCs from below the epithelium. So for that, the thickness of the epithelium has to reduce, just the opposite of that of leukoplakia. So here the thickness of the epithelium will reduce, and the blood vessels in the underlying connective tissue will be very close to the surface of the epithelium because the thickness is less. So the distance, the red colored light of the emitted by the erythrocytes or the RBCs in the blood vessels, that time it will, or the distance it takes to travel to the observer's eye, that is, you're the doctor, when you observe the lesion, your eye will be able to catch that red color more faster because that red color will come more faster because it's coming from a closer area in the connective tissue. The blood vessels have moved up in the connective tissue because the epithelium is thinned down. All right. So, which is why you are able to see the red color. Now, let's see what is written. Now, histological features, you can actually see that histologically in the biopsy that maybe the lesion is a dysplastic lesion, maybe it is a carcinoma in situ or a squamous cell carcinoma. What I mean to say is the lesion can show features of dysplasia either only in the lower third or lower middle third or in the lower middle and upper third. That means it can be either mild dysplasia, moderate dysplasia or severe dysplasia, but dysplasia will be present. Or the next stage, it can be a higher grade. You can see dysplastic features from the topmost layer to the bottommost layer. Or you can even have a squamous cell carcinoma. Maybe the dysplastic cells have already invaded the underlying connective tissue and caused a malignancy. So histologically, an erythroplakia can either be a dysplasia, a CA in situ, or a squamous cell carcinoma. So as a pathologist, if you get the biopsy, you are going to give the diagnosis based on what you see on the slide. So what will be my diagnosis? Suppose my patient has got carcinoma in situ. So I will write all the features of carcinoma in situ, and I'm going to say that correlating clinically, the erythroplakia, which was clinically diagnosed, is showing, in this case, showing features of carcinoma in situ. That means you're very clear that this a red lesion can be anything, but in this particular patient, it is a carcinoma in situ. So it's very important for you to know what stage the red lesion is in because the treatment will differ. If it is a squamous cell carcinoma and a red lesion, the entire tongue will be removed. But if it is just a dysplasia or a carcinoma in situ, only that area of the tongue will be removed. The rest of the tongue will be available for the patient. All right. So you have to be very correct in your diagnosis. Now, second, you will find an atrophic epithelium. What do you mean by atrophy? Thinning down of epithelium is called as atrophy. So when there is a thin epithelium, the distance that the red light of the RBCs will take to travel to your naked eye is much lesser, as a result of which you will find a red lesion. Or it can even be due to lack of keratin production. That means keratin produce karenge, so it can be a white lesion. But if there is no keratin, that means it is another reason for the lesion to be red in color. Now, what will happen when there is an atrophy of epithelium? Whenever there is an atrophy of epithelium, obviously there will be chronic inflammatory infiltrate. Now, what is inflammation? It is the host's way of saying, yes, I am responding. Whenever there is a disease or a stimulus or an external insult, whatever, immediately your body is going to respond with an inflammatory reaction. The first inflammatory reaction to a trauma will be redness, to a viral infection will be fever. So all this is your inflammatory reaction by the body. So inflammatory reactions can occur in a chronic stage when the inflammation exists after 24 hours also. So a chronic inflammatory cells can also be seen in the connective tissue when the thickness of the epithelium goes down. All right. Now, what are the reasons? The connective tissue pegs will extend very high into the epithelium. Now, what are connective tissue papillae? Now, if you go back to your normal epithelium, we know that the epithelium has got Reiter ridges. Okay? So, the Reiter ridges are nothing but the epithelial projections into the connective tissue. So, in between, when the epithelium comes down into the connective tissue, don't you think so? The connective tissue is also alternately going up into the epithelium? Yes. So, those connective tissue papillae, because the epithelial thickness has reduced too much, have gone very high into the epithelium, due to which the underlying blood vessels can be seen very clearly, and that is why you find a red color for erythroplakia. So histopathology is very important for an erythroplakia. Now coming on to this is just a way of diagnosing white lesions, which in which you can see onto your left side, you can see that there is history taking, examination of the patient, and biopsy. Very important. So it is history is taken by you in the clinic, examination is done by you in the clinic, biopsy is done by the surgeon, and then it is sent to the pathologist. So all the three stages are very important. I, as a pathologist, cannot just say that I will not look into the history or the examination details and give a diagnosis. No, I need the clinician to give me the correct information before I go into the correct diagnosis. So, if a suspicious oral lesion is seen, it can be either in a male or a female. You have to see the age, because there are certain lesions which are seen more in males and some lesions which are seen more in females. You have to see the age. If the age is more than 50 or less, non-smoker or smoker, because most of the smokers will develop these kind of lesions. Persistency of smoking, how many years since he or she has been smoking, that increases the risk. The site of lesion, the posterior surface of the tongue or the lateral aspect of the tongue or the floor of the mouth, will give a extremely high risk of malignancy. It can be either a white lesion, then you call it in the clinic as a leukoplakia in the first step. If it's a red lesion, you call it as an erythroplakia. Now the leukoplakia, again, you will look at the type of leukoplakia, if it is homogeneous, uniformly white, or it is non-homogeneous. Matlab, is it red and white? Then you call it as a speckled leukoplakia. Or if it is a irregularity in terms of the surface, that is, it's a cauliflower-like lesion, you call it as a verrucous leukoplakia. Now, if you find a lot of these cauliflower-like areas and the patient says it's been there for a long period of time, you would call it as a PVL, proliferative verrucous leukoplakia. All right, so that is a scarier thing to have again. Now, erythroplakia is also very scary to have. So you would rather take a biopsy of the erythroplakia. And in the histology, when you take a biopsy in the histology, you would see either it is a mild dysplasia or a moderate dysplasia or a severe dysplasia. So mild and moderate dysplasia, you can actually tell the patient that, okay, your risk is not very high. You can still go back to being normal. Okay. But in case of high risk leukoplakia or erythroplakia, you have to tell them, if the severe dysplasia is there, that your prognosis might not be that great. All right. So this is how you will come down to diagnosing a red and a white lesion. Now coming on to the next white lesion, that's called as a leukoedema. All right. Leukoedema actually is the precursor for leukoplakia. Now if I use the word precursor, I would rather say that leukoedema is the first lesion which will come in, which will be followed by leukoplakia. So leukoplakia is a very clear white patch which you can actually identify and say that, yes, this is a white lesion and this is leukoplakia. It is associated with tobacco. But leukoedema is actually not a very clear white lesion. But then, yeah, you can see it. And then sometimes if you stretch the mucosa, you might not see it. So etiology can be tobacco, or it can be other reasons like the pH of saliva. Acidic saliva can increase the amount of leukoedema. All right. Then it may later on develop into leukoplakia. That's why I use the word leukoedema is a precursor to leukoplakia. So the clinical feature would be a grayish white, filmy white opalescence. Now I want you to understand that word opalescence. So opalescence ka matlab hai, it is not very clear. It is there, but it's not really clear and well circumscribed and well defined like a leukoplakic patch. I'll show you a picture that will make it more easier for you. It might have a very coarse, rough, wrinkled surface. They can be bilateral lesions. You can see it on both the sides of the cheek. Most common site is occlusal line in the premolar region. Okay, so because it's actually not a potentially malignant lesion, but it is included in this because it is a white lesion again. So occlusal line, when you close your mouth, there's a line which forms along your occlusal surface of your upper and lower teeth. So that is called a occlusal line, can be white in color. Then desquamated areas may show erosions. Now I want you to understand the word erosion. Erosion ka matlab hai, the superficial layers of the epithelium are lost, but not the entire thickness. That means the basal cells will never be lost. The basal cells and the basal membrane will be intact in an epithelial erosion. Only the stratum spinosum, granulosum and corneum can be lost. So which means the thickness of the epithelium can be lost in some area. So that is called as a surface erosion. All right. Or desquamated areas. What do you mean by the word desquamation? As I said, older epithelial cells in the stratum corneum will by itself be lost from the body naturally. So that is why you use your facial scrub and scrub out the dead skin. So scrubbing out dead skin is called as desquamation. All right. So the squamous cells, when they're lost normally, is called as desquamation. So sometimes in certain areas, the desquamation or the loss of the squamous cells will be more prominent, as a result of which you might have surface erosions. So you have to differentiate between a surface erosion and an ulceration. All right, this is a concept which will be asked in the exam. I want you to be very clear with it. An ulcer is when you lose the basement membrane and the entire thickness of the epithelium, and there is a little bit of connective tissue which is exposed to the outer side. That is called as a ulcer. But an erosion is something different. An erosion will have a very well placed basement membrane and basal cells. Only the topmost layers of the epithelium will be lost. So in an ulcer, you will find a yellow colored pseudomembrane, but in an erosion, you will only find a red color. All right. So that is leukoedema. It's a white opalescent lesion. Now look at the picture. You can see that there's a white area, but you really can't appreciate where the white area is blending to the normal mucosa. So it's a very opalescent stage. Okay. So this is called as a leukoplakia, very commonly seen. So histological features, you will find increased epithelial thickness, and very important portion you have to understand to differentiate between the white lesion, again, if it's a leukoplakia or a leukoedema, is that when you take a biopsy, you should be able to see intracellular edema in the spinous layer. Now, what do you mean by intracellular edema? Edema is basically a little bit of, fluid accumulation in the cells. Now, how will you find intracellular edema? You will find that the cells are looking all puffed up, larger in size. There'll be a nucleus, but cell will appear a little larger in size. So that is called as intracellular edema. Where you'll find it? You'll find it in the spinous layer, that is the stratum spinosum or the prickle cell layer. All right. So that's called as increased intracellular edema. Or then in the upper layers, you can see hyperparakeratosis. I told you, whenever you have increased keratin, you can find a white color. All right. So broadly or irregularly elongated retapex, large pale edematous cells. See, again that word came, large pale edematous cells. So basically the intracellular edema or the large pale edematous cells are very important. So there are chances that the cell has become so large that the nucleus is there, but it appears to be absent. You're not able to see the nucleus. All right. So that is about leukoedema. Coming on to the next lesion, that is palatal changes in reverse smoking. Now, this is extremely important because before going into palatal changes of reverse smoking, let me explain the habit first. Now, in India, smoking is still not a great thing. I mean, yeah, it's considered to be very cool for the younger generation, and they start doing it because they find it very cool, but it's a very addictive uh, uh, habit to have. So what happens is, as the patient starts to smoke, they get into this habit of smoking, and then they're unable to leave it. Now, this is about the urban population. But when we talk about the rural population, we would know that the older generation would have had these BDs and unfiltered cigarettes for a long time. But in the female population, it's not considered to be a great habit to have. So that's a taboo which is there in the society. So there are some places in India like Srikakulam in Andhra Pradesh, Vishakhapatnam in Andhra Pradesh, and also some areas of Goa. So these are two areas in India where it has been seen that people keep the burning end of the bidi or the cigarette inside the mouth. It's not a cigarette, basically it is mostly bidi. Bidi is actually just rolled by the hand and in a tobacco leaf, and actually it is not a filtered cigarette. So it is not filtered, so it is more harmful. So bidi is more common in the southern part of India, and it is more like rajnigandha and all those things are very common here. Bidi is very common, and the bidi barons are like, they make huge amounts of money. So they are like big business tycoons. So these are the people who sell these bidis with tobacco to the the poorer sections of the society. So what they do is, these females basically, they they don't want people to see that they're smoking, so they light the bidi and they keep it upside down, you know, the burning end, they keep it inside their mouth. So what happens is they kind of tend to burn their palate. Obviously, every day if you do the same thing, it becomes very habitual, so you tend to burn the palate. All right. Another reason why they have this kind of a uh, habit is, most of these ladies, they do work as well as they also have to take care of the children. So they would be working in some kind of a cottage industry, or even at home they want to take care of their children. They don't want the ash of the bidi to fall on the child's face, so they say that we keep it inside, the burning it inside, so that, you know, the ash doesn't fall on the child's face. So they give different reasons for which they use this reverse habit, of smoking. Whatever be, unknowingly the palate gets burned all the time, and habitual burning of the palate leads to a lot of these changes which are potentially malignant. So in the picture you can actually see, if you can appreciate this one dot like red area, and a white area surrounding that, and you can see that there's a lot of keratinization which is not very uh, uh, uniform. It is a very non-homogeneous lesion, and you can see some red areas over here. Now these small spot-like red areas are nothing but the dilated and keratinized and inflamed opening of the minor salivary glands. So there are a lot of minor salivary glands on the palate. So these are the ones which are actually become very prominent, and that is how you see them. All right. So this can, over a period of time, lead to ulcerations, ulceroproliferative lesions, and into oral cancer. So now let's come to, I will go have a fast reading. Now this is a pre-malignant lesion. This was considered to be a pre-malignant lesion earlier. Now it is called to be a oral potentially malignant disorder. Smoking with a lightened end of the cigarette inside the mouth, seen in adult fishermen in Andhra and Orissa. It's called as adda poga in local dialect. Poga means smoke. All right. Then smoking device can be a homemade cigar, which made by crudely rolling a few dried tobacco twigs called as chutta. Then lit end of the chutta is kept inside the mouth and then closed. Lips will seal and the mouth will allow slow inhalation of the smoke, which is let out from the unlit end. All right. So that's how I've already explained it. I've shown you the picture. Now it's seen more in females. I told you the reasons. They don't want to let their husbands know that they're smoking, or they don't want that to come down on their children when they're kind of nursing their children, or they don't want it to go off, the lighted end be extinguished, by lit end to extinguish due to strong winds of water. Or fisherwomen might also use it during weaving to prevent weaving, to prevent the hot ash from falling on the fishing net. So they're weird reasons, but they have their own reasons to do that. So the habit has also been reported from Philippines, South America, and the Caribbean. So what happens in clinical features, you will find that hyperpigmentation and excrescences are there. That means you will have more of colored areas. There'll be a lot of melanin production initially. Smokers will have increased amount of melanin production, that you must have already seen in smokers. They'll have dark lips. All right. So and you'll have excrescences. You saw in the picture that the area was not uniform. There was a little non-uniform outgrowths. All right, that they're called as excrescences. So there'll be areas of depigmentation. The initial kind of body's reaction will be pigmentation, and the next reaction will be depigmentation. Initially it will increase the amount of melanin, and then it will reduce the amount of melanin. So you will see areas which are white in color, and you will see areas which are dark black with melanin. So the other things you'll find is palatal keratosis, a lot of white areas, palatal thick keratosis as you saw in the picture. You might find leukoplakic areas, ulcerations, and frank malignancy. So this is the most, by and large, very dangerous lesion to have. So hyperpigmentation will be well-defined gray-black pigmentation of the palate due to increased melanin production. Protective reaction, it is basically when does your body produce more of melanin? When it has to protect yourself. That is why even though we are brown skinned, we have more protection from sunburn, the sunlight, UV rays of the sunlight, because we have good melanin. A white person, if he stands in the same sunlight at 48 degrees in our summers, he would get a sunburn and can lead to a skin cancer. So what I'm trying to say is melanin will protect us from a lot of toxins. So hyperpigmentation in the palate due to smoking is also a protective mechanism where it is protecting from the smoke or the carcinogenic events from the smoke. Now, why will depigmentation happen? That is because the tobacco will penetrate into these areas and develop into red spots. I showed you one area which was dilated salivary gland duct. And melanin is also a natural antioxidant. So it will scavenge the tobacco toxins. So what do you mean by scavenging? It will remove the toxins of the tobacco. That is why melanin has a protective uh, effect. All right. So excrescences, as I told you, are small elevated areas which you find in the palate. I showed you that small red dot which was elevated, and I told you that's dilated duct of the minor salivary gland. So they can be papular elevations. Papule matlab elevated area is called as a papule, which is 2 to 3 millimeters in height, elevated. Central umbilication. Umbilicus kya hai? Umbilicus is a little depressed, right, on your stomach. So umbilication ka matlab hai, on the center of the papule, this elevated area, you will find the center is a little depressed. All right. So that is an umbilication. So it is reversible on discontinuing the habit. Malab, you stop keeping the burnt end into the inside the oral cavity. Slowly the lesion will heal. All right. But if you don't, then it can go into a microinvasive carcinoma. So the risk of developing malignancy is 47 times more than that of a non-smoking female. So that's about it of about the palatal changes in